Well, thank you very much, Dr. Lesego, for that introduction and for hosting me on your platform, and also thanks to AbbVie for sponsoring this. I don't know if Lesego mentioned, if you've got any questions, please type them in the Q&A. No, Lesego will answer some of them on the way, and then I'll answer the rest. A bit of discussion afterwards. Cool. He always chooses the nice ones to answer. Leaves me with all the difficult ones. Okay, but that's fine. All right, good. So I'm going to be talking about patients, the very few patients that we have, but the ones that are really difficult to manage, those who have got extensive HIV resistance. Okay, these are my disclosures. So really we're talking about third line and beyond. And what is third line? So traditionally third line would be patients with protease inhibitor resistance, but now we're including those with integrase resistance as well. But the problem is that with dolutegravir, the borders are becoming very blurred because dolutegravir is being used first line, second line, and third line. So it becomes very difficult to say it's a third line patient on TLD, but they're a third line patient. So I'm speaking about the traditional patients that we traditionally called third line patients, but as I say, with DTG it's becoming very, very blurred. This is an overview of what I'm going to be talking about. Okay, let's do a poll. Poll number 1. Which of the following could be contributing to the development of PI or integrase resistance? Prolonged time on a protease inhibitor regimen, an interaction between rifampicin and the PI, or rifampicin and the integrase inhibitors, interaction between polyvalent cations and dolutegravir, previous unboosted PIs, or transmitted resistance. Yeah, I think people seem to know this very well. I think we can end the poll there. We've got a good idea of how the pattern is looking. And there are other polls. If you didn't manage to answer, we'll give you some others to answer. Okay, so it's multiple choice. So it seems like the most popular one was transmitted resistance. Interesting. Previous unboosted PIs, I think next was interaction between the rifampicin and PIs and integrase are very good. I think that's definitely a very common cause that we see, especially in children. Previous unboosted PIs is also up there. And the last one was, we'll say, with the last two, the tie, polyvalent cations and dolutegravir and prolonged time on a PI regimen. Okay, very, very interesting. I'm hoping that we'll answer those questions as we go. Lesego, did you see Lisa's, are you going to sort that out? Great, thanks. All right, so what are the causes that we are seeing? So there's no question, and you'll see, I'll show you the data. A prolonged time on a PI regimen is an important cause. Interesting, that was sort of the last one that people thought of, but that does, especially in adults, that does seem to be what is associated with PI resistance. We don't know about integrase inhibitor regimens. Certainly those patients on first line integrase inhibitor, virtually never, dolutegravir, I must say, virtually never develop resistance. So we don't know if they're on a particularly long period of time, whether they're going to develop or not. That time remains. The interaction between rifampicin and the PI and integrase is very, very important, and we certainly are seeing that. Other interactions, we're not seeing that yet, but we know that things like the polyvalent cations and the anti-epileptics and antacids do reduce the absorption of dolutegravir. So there's no question that theoretically that could cause a resistance to dolutegravir. Previous unboosted PIs, predominantly full dose ritonavir. We used to see that in pediatrics. It's not a common cause now, but we certainly did see that. There's no question. And transmitted resistance, I think, is pretty low because we're not seeing that much resistance. So to transmit that, I think would be even more uncommon. So yes, it would happen, but I don't think it's a common cause of people having PI resistance or integrase resistance. And PI or dolutegravir monotherapy, remember in the studies, the earnest study and in the dolutegravir monotherapy studies, they did result in resistance. So you definitely do not want to use those drugs in monotherapy. Okay.
Dr. Leon, on option 1 there, you said the prolonged time on protease. Is that quantifiable? Is it something easily quantifiable?
We will get there. If you still have that question at the end, then
okay.
then obviously you had load shedding.
Super.
Okay, cool. So the third line committee has got this algorithm. Remember, this committee has been in existence since 2013, and its algorithm has been validated in adults but not in children. But these days, frequently, if people can find a dolutegravir, active dolutegravir plus an active NRTI, they will rather go for that and bypass this algorithm. And this algorithm actually is in the process of being updated. But I think it's a good starting point when looking at these patients. So in the adults, you would have your eligibility requires PR resistance, either lopinavir or atazanavir, and they will all get darunavir or ritonavir, right? The new kid on the block in terms of protease inhibitors, and they'll also get 2 NRTIs, PTC or FTC plus tenofovir or AZT, whichever is the least resistance, and that may be good enough. But if it's not, if they've got some resistance to the TDF or AZT or low-level resistance to darunavir, you add in dolutegravir. And if not one or the other, but both, if you've got NRTI resistance and you've got darunavir resistance, then you'd add in etraverin. So that's how it works. Depending on how much resistance they have, you might have 2 NRTIs plus darunavir ritonavir. If you've got more resistance, adding dolutegravir. If you've got even more resistance, adding in etraverin. The etraverin is not the greatest drug in this situation because, first of all, it's got a big pill burden. We'll see later on. And also, it's a non-nucleoside, and we don't do resistance testing generally when they're on a first-line non-nucleoside regimen. So we don't know if there's resistance to etraverin or not. So for that reason, it's not the greatest choice. And in fact, the third-line committee is frequently omitting the etraverin because these patients are actually doing so well just with TLD plus darunavir and ritonavir. But that's the algorithm. As I said, it has been validated, and this is the study which they published, the validation. And this was in the old days when they didn't even have dolutegravir, they had raltegravir. And if I remember correctly, 80% of the patients at a year had a viral load below 1,000 copies per mole. So it is validated. What are the third line algorithms in children? So it's very similar in children who are over 3 years of age. They are going to get it's very similar, darunavir plus 2 NRTIs, but obviously you can't use tenofovir in children under 10 or under 35 kilos. So they would get AZT or nabacavir. And then if that's not good enough, then they would get if there's intermediate resistance to the NRTIs or low level to darunavir, then you add in raltegravir if the child is under 20 kilograms, or dolutegravir above 20 kilograms. We don't generally like to use raltegravir because it's got a low barrier to resistance, becomes resistant very easy, and causes cross resistance to dolutegravir. So we will try and use dolutegravir where possible, and I'll go through that with you later on. And then obviously if they've got more resistance in that, then we'd add in etraverin. So that's very similar to an over the age of 3. All right, poll number 2. Why is darunavir ritonavir contraindicated in patients who are under 3 years of age? The patients under 3 years of age, you can't use darunavir ritonavir. Why would that be? And different possibilities. There's only one correct answer. It either causes allergic skin rashes, causes thrombocytopenia in baby rats, causes convulsions in baby guinea pigs, causes convulsions in baby rats, or causes hallucinations in baby armadillos. I don't know who wrote this thing. It's cool. All right. Very, very interesting. I think all the animals confuse the people.
Yeah, we're trying to get the right animal.
Yeah.
Clinical issue.
Yeah. Okay, that's a minute up. I think let's end it there. Okay, let's share the results. There's some smiley faces floating up my screen. Are they supposed to be there? Or are they crying? I'm not sure. Okay. All right. So the correct answer is number 4, because convulsions in baby rats. So all of the others, you guessed all the others. Some of you got the rats right, but didn't get the disease. Okay, so it causes convulsions in baby rats. And that's why we don't use Durina ritonavir, the black box warning. We don't use it in patients who are under 3 years of age. Okay, so that's why it's problematic. So if you've got a child who's needs third line and they're under 3 years of age, so generally in that situation, the third line committee would decide on an individual basis which third line drugs to give that patient. Okay, let's look at adults. What are the causes of protease resistance in adults? So the common would be the prolonged time on protease inhibitors, and the Cephas question comes in here. And then second would probably be the interaction between rifampicin and lopinavir ritonavir. And unusual would be previous unboosted PIs or transmitted resistance. Okay, so this is a meta-analysis which answers the Cephas question. On the y-axis, we are seeing the proportion with major PI mutations from 0 up to 40% up there. Okay, and time on the right axis. And you can see that for the first, where are we up to? 20, probably up to 20 months. There is literally no resistance, a little bit of resistance we're seeing there, but the bulk of the resistance is sitting around about the 2-year period. So that is the biggest contributor to resistance, is them being on a period of 1 to 2 years, but close guidelines take 2 years as a cutoff. And you can see the bulk of the resistance is happening after that 2-year period, or you could say after 20 months. Okay, so they need to be on a PI for a long period of time before you're going to see resistance. And that's why our guidelines say that, you know, patients must be on a PI regimen for more than 2 years before you do resistance testing, because otherwise there won't be resistance. So for the first 2 years, literally, it's purely an adherence issue. After 2 years, that's where resistance starts to kick in. There are a couple of cases, as you saw. This is not 100%, but from a public health approach, really, you're looking at that 2-year period. Right, what about TB and lopinavir ritonavir? So you can see in the top graph that the top dotted line is a patient who's not on TB treatment, taking the lopinavir ritonavir. That's the lopinavir ritonavir levels there. And the one below is a patient who is taking TB together with it, and you can see that the graph is much lower. And the most important one, you want to look at the trough. Okay, the trough of that graph is below the magic number of 1. Okay, you can see the dotted line recommended trough in ART naive. Okay, it's below that, and so that is problematic. Yet the bottom graph, if you double dose the lopinavir ritonavir, you can see the two graphs are virtually superimposed, and so that solves the problem. So in adult patients who are on lopinavir tablets, you double up the lopinavir and you solve the problem. What about atazanavir and darunavir with rifampicin? So at this point in time, we don't have any data on what you can do to modify the atazanavir or darunavir. So your options are to change to lopinavir, which we double dose as we discussed, or you could use rifabutin rather than rifampicin. We'll talk about that later. It's a bit problematic. Okay, or you could change to a dolutegravir regimen dosed 50 milligrams twice a day. But you couldn't leave them on atazanavir or darunavir. And we've seen patients who develop PI resistance because they were on those other drugs and it wasn't taken into account. The TB treatment wasn't adjusted for. Okay, what about children over 3 years of age? What are the causes of PI resistance that we're seeing in those children? So there are very few patients left who started on an unboosted regimen. There were in the old days. Okay, they started on full dose ritonavir because they were either under 6 months of age or they were on TB treatment, but that's been done away with. And those kids are now young adults. They're most already on third line. And so we're not seeing any new patients who are on unboosted PI regimens. The interaction between rifampicin and lopinavir ritonavir is there for sure, and also the prolonged period of time. But also it's a bit of confusion because people don't always react straight after 2 years, do the resistance testing and then get them onto third line. So they've got patients who may have had unboosted regimens with TB treatment, but have still been on the regimen for a long period of time. So now it's very hard to tease out what is actually the cause. And it's probably a little bit of both. Okay. Children under 3 years of age, very common to see children who are young babies or put into TB treatment and it's not correctly boosted, and so they develop PR resistance. Transmitted resistance does happen, but it's relatively uncommon. And I'm just wondering whether, in fact, we're not missing it. So someone has asked, is non-adherence an issue? Yeah, well, they didn't look at non-adherence, but the one thing that seems to be quite clear is that you have to have been on that PR for a good 2 years to get resistance. Before that, if they're failing, it's non-adherence. Okay, but if they're over 2 years of age, that's when you start to see resistance as well from the non-adherence. So non-adherence, you can see it at any stage, but there is a distinction in that 2 year period of time between a non-adherent patient under 2 years and non-adherent patient over 2 years. That's when you start to see the resistance. So obviously they've got a good capacity to endure this non-adherence, but when it gets to a point where you start to develop resistance. Okay, so let's have a look at these children on lopinavir and rifampicin in a poll. And what would be the correct options? And it's also multiple choice. Which of these options are correct for patients who are on lopinavir and rifampicin? Okay, you've got to read it very carefully. Could you double dose this lopinavir solution, double dose the lopinavir tablets, super boost the ritonavir solution with extra ritonavir solution, or super boost the lopinavir solution with extra ritonavir tablets? Or I think that's a spelling, it should be powder. So the last one would be super boosting with extra ritonavir powder, but you could put tablets in for the same. If you look on the screen, you'll see I've got powder there. That's a bit of a typo, sorry about that. Okay, I think let's end that there. Let's show the results. So the correct, well, let's go through double dose solution. Okay, we'll come to that. That's not exactly correct. Double dose tablets, yes, that is correct. The lopinavir solution super boosted with extra ritonavir would be correct if you could get hold of the solution, but it's been discontinued, so you can't do that anymore. And the last one, lopinavir solution super boosted with extra ritonavir powder, that would be the correct one. You could use the tablets if the children could swallow the tablets, but obviously these are young kiddies, they wouldn't be able to swallow tablets. Okay, so let's look at those in detail. It's very, very important. So here you can see some of you said double dosing the solution. Okay, this is what happens if you double dose this solution. Right, so your controls, you can see the trough 4.25, well above 1. Okay, double dose the lopinavir solution 0.63, below 1. Okay, we never double dose the solution in children because they get PR resistance. You can see it. Here's a clear, very clear. The tablets, yes, but not the solution. The solution cannot be double dosed. So what can you do with the solution? You can super boost. You can give extra ritonavir to take the ratio of lopinavir ritonavir from 4 to 1 to 1 to 1. Okay, you add in extra ritonavir, and you can see the two graphs are exactly identical. On the left were those patients who had rifampicin but had super boosting, so it was 1 to 1. On the right, the same patients where they were off their TB treatment, and now they no super boosting, just the normal 4 to 1 lopinavir. The two graphs are exactly the same, suggesting that is a very acceptable thing to super boost. But double dose young children on solution doesn't work. They end up with PR resistance and third line. So at what age can we double the dose? The truth is there's no data. We know young children under 3, you can't double dose. Adults, you can double dose. So this is where we sort of end up with expert opinion. Dr. Helen McKilleran, who did the original studies on double dosing in children, she said 5 years and swallowing the lopinavir tablets. Remember, the lopinavir tablets are much more bioavailable than the solution. So she said that would be good, because also the liver is matured by 5 years of age. She later changed the story and said, if they're just following the tablets, that would be good enough. but they must swallow the tablets whole. Remember, you can't crush them, and you can't chew them. And so that's what our guidelines are saying. If they can swallow the tablets whole, then you can double the dose with rifampicin. But we do need data because children as young as 3 years can swallow tablets, and we do need to know. Okay. All right. And if you look at our latest 2021 dosage chart, you'll see this green column in the middle. That is what you do with patients who are on lopinavir, ritonavir, and rifampicin. On the left is the oral powder. As I said, the solutions we discontinued, so you'd add the oral powder. It tells you exactly how much to add. We try and make it exactly a whole sachet, 1, 2, 3 sachets of the powder, because if you're using smaller than 100 milligrams, which is less than a sachet, it's like a nightmare to draw up, like 11 steps to draw it up. So we'd rather keep it as 1 sachet, 2 sachets, or 3 sachets. And on the right in the green is the double dosing the patients, but they must be able to swallow the lopinavir tablets whole, then you can double up the dose. Okay, so to summarize the oral powder, the shelf life is 36 months. And unlike before, where the solution had a shelf life of 6 months, couldn't keep in the clinics, it was expiring all the time. They'll be able to keep in the clinics, it'll be visible. Hopefully people will use it. Use the whole sachet and mix it with food or liquid. Must be used within 2 hours, but still tastes terrible. Hopefully we'll see less PR resistance in this situation. So to summarize, if the patient is taking lopinavir tablets, you can double the dose, even in children. If they are taking lopinavir solution or lopinavir, let's add the others, the 4-in-1 or the lopinavir pellets, then you would have to super boost with extra ritonavir. Okay, so let's just show you a case quickly. 18-month-old baby at 9 months was given a backup of 3-TC lopinavir ritonavir plus rifampicin containing TB treatment, and which was unboosted. And if you can see the resistance test on the left, the top, the PR mutations, you've got 2 major PR mutations. So the patient already got high level lopinavir resistance, intermediate atezanavir resistance, susceptible still to darunavir. And on the right, you see the typical picture we see with the BACABA 3TC, where we've got the 74V is an BACABA mutation, the 115F is also a BACABA, and the 184V is a 3TC mutation. So that's a typical picture we see in these young babies who've had TB treatment and now they end up with PR resistance because it wasn't correctly boosted. Okay. Here's another one I just want to show you. A 7-week-old baby, mom was failing second line AZT3C lopinavir ritonavir. She previously had T4T, 3TC efavirenz. Okay, and this is the resistance test done on the baby. You can see 1, 2, 3, 4 major PR mutations. So we've got high level atezanavir and lopinavir resistance, low level darunavir resistance. We've got a whole string of TAMs here as well, thymine animal mutations against the AZT and D4T, because remember the mom was an AZT and then previously D4T. So also got a non-nuke for her first line regimen, triple class resistance in a young baby, transmitted resistance. Obviously this is a extreme case, but it does happen, and just to be aware. And that's why if you look at our indications for doing resistance testing in young babies, any newly diagnosed child under 2 years of age whose mom was on a PR regimen, you do a baseline resistance test in that mom so that you're aware of what's happening in the baby. Okay, the other indications in children would be a child failing a PR or dolutegravir regimen for a period of 2 years with 3 high viral loads during that time of above 1,000, or TB treatment together with a PR or dolutegravir. That would be another indication. And then you don't have to wait for 2 years because that would develop, resistance would develop much more rapidly. Just for completeness, let me show you the adults indications for resistance testing. So here it's just a PR regimen for 2 years. At the moment, the dolutegravir would not, you would just change the second line. You would not do resistance testing for first line dolutegravir failure, but for second line dolutegravir failure, then an expert may authorize resistance testing in that situation. Also, PRs or dolutegravir together with TB treatment and unboosted ART would also be an indication for resistance testing. And the third one, last one's probably going to fall away. Patients who's been on PrEP in the last 6 months and then seroconverts, they said to do resistance testing. But we know from the NADIA study that even if there is resistance to tenofovir, it's not the end of the world. So that probably will fall away in the new guidelines. Okay, now I want to talk a bit about the drugs that we use in these extensively resistant patients. So darunavir, as you know, is a protease inhibitor. The solution we really don't use is section 21, which is quite difficult to get hold of, a bit of a pain. We rather use the tablets, which are crushable. There's 75 milligrams, 150, 400, and 600 milligram tablets, which are crushable. There's a 400/50 tablet, which is not crushable. So what's a 400/50? It's 400 milligrams of darunavir and 50 milligrams of ritonavir. Okay, with the aim of putting them together to give you an 800-100 combination for once daily darunavir. We'll talk about that just now, I think in the next slide, but that's not crushable. But the other ones are crushable, which generally, you can give it once daily or twice daily, depending on resistance to darunavir, and I'll show you that now. As we said, not to be given under 3 years of age. Ritonavir, there's a powder, which is 100 milligrams in the sachet, and the tablets, they are 100 milligrams. At this point in time, they can't be crushed. It seems like there may be a move to change the package insert, but we're still waiting for more data on that. And that generally, because it's so difficult to use this less than 100 milligrams of the powder, we would often overdose and give the child 100 milligrams, even though the dosage says less than that, just to make it easier for the patient. They can give the whole sachet, they don't have to break it up. There are a couple of questions we can quickly go through. The physiology, I think we've discussed that. It's basically, it's much more than we can do in this talk. The doses of the oral pellets of the ritonavir would be exactly the same, and that's on the dosage chart. Okay, Lucejo is giving an answer to that. Okay, and slides, yes, we can make a plan. Cool. Right, so a few years ago, the Clinician Society put out this guidance on the appropriate clinical use of darunavir 800 milligrams, because it's very confusing. All right, so let me go through it with you. So in the old days, the dose of darunavir was 600 milligrams plus 100 milligrams of ritonavir twice a day. Right. And then they discovered that you could use it once a day in a dose of 800 milligrams of darunavir and 100 milligrams of ritonavir once a day in patients who did not have resistance to darunavir. And they came up with a whole string, 11 different mutations that we call the darunavir mutations. If they have any of those, then you can't give darunavir once daily. You have to give it twice daily in this dose of 600/100. The Clinician Society made our life a little bit easier and said, well, you know, if you do the Stanford database and you find a score of 0, then you can give it once daily. If it's above 0, in other words, if there is any darunavir resistance, then you have to give it twice daily. So the twice daily is going to be patients with darunavir mutations or a Stanford score above 0 on any of the genotyping. And the once daily 800 plus 100 would be given in patients who are PI naive, so they've never had a PI before. They're suppressed on a second-line PI regimen. You can switch them to the once daily regimen. And if the darunavir score is 0 on all genotypes, then you could give it once daily. Okay, as I say, there's a 400/50 tablet. So if you give the two together, that gives you the 800/100. So you'd use it in PI naive patients who are really suppressed on a second-line PI regimen. You're changing, for example, the patient on atazanavir, they're getting jaundice. You want to change them to a once daily regimen. You can change them to 800/100 of darunavir. And if in a third-line patient, even though they've got PI resistance, but the darunavir score is 0 on all genotypes, then they could get it once daily. Now, we didn't know this in the old days when we first started doing PI in 2013. We third-line resistance in third-line patients in 2013. So all the patients went on to twice daily darunavir. But there is definitely scope now to look back at those patients and say, well, let's look at the resistance and see maybe they could qualify for once daily and we could switch them to a once daily darunavir regimen. Also, if you do the Stanford database, you put the mutations in, under the comments, it will come up and say there's evidence for intermediate darunavir resistance. If darunavir is administered, it should be used twice daily. So you can use that as well. Okay, if it doesn't come up with it, say twice daily, then you can use it darunavir once daily as well. All right, what about once daily darunavir in pediatrics? So yes, you can do it. indication would be the same as in adults. There are FDA approved once daily doses. Not everybody agrees with them. The American guidelines say they would rather not give it once daily, but we've been using it once daily. We're quite happy to do anything that simplifies our patients' lives. And once the FDA is approving it, it's certainly quite an august body. And we've had no problems with the once daily Darunavir. There are doses, and you just discuss with an expert, they'll be able to help you in that situation. The one problem we are encountering now is that some of these patients are going to be on 400 milligrams of Darunavir, but plus 100 milligrams of ritonavir. So you can't use that fixed dose combination of 450, because then you're going to sit with how you're going to get 50 milligrams of ritonavir. And that's creating a bit of a problem at the moment, because you can't always get hold of the 400 milligrams on its own. The singles, they seem to be, the combination seems to be more available. But doesn't mean we shouldn't try, and definitely would want to try and get them onto once daily regimens. Okay, in terms of dolutegravir, so we have at the moment the 50 milligram dolutegravir tablets. These, as you know, this 10 milligram score tablets have been registered at SAPRA. They'll be in the new guidelines, which should be out in the next couple of months. Okay, the dolutegravir regimens will probably be available in early 2023, early next year. But remember that the film-coated, which is the one we have now, and the dispersible are not bioequivalent, and the factor of 1.6. So here you can see it quite clearly. If you look at the bottom, child over 20 kilos would get 50 milligrams once a day of the film-coated. That's the one we have at the moment. Whereas if you're using the new dispersibles, the dose can be 30 milligrams. So 30 times 1.6 gives you 50. So 48. So we're almost 50, right? So that's your conversion factor. So they're not bioequivalent. Right. Now in this table, what I've done is I've taken the doses of the dispersible tablets, which we hopefully will have next year, and said, well, sometimes we have patients now who need dolutegravir for third-line purposes, but they are under 20 kilos. What can we do with them? And what I've done is I've put in the approximate dose, just multiplied by 1.6, giving us the approximate dose. And this is what we get, okay? Putting in all for those weight bands. And you can see not much we can do about 8 milligrams, but 24 milligrams we can do. It's a half a tablet. We can give them a half a 50 milligram tablet. So any patient who is between 6 and 10 kilos could definitely, in extenuating circumstances, get half a dolutegravir tablet once a day to tide them over until we get the pediatric formulations. Right. The other one where we certainly could make use of it would be patients who are over 14 kilos, where the dose should be 40 milligrams of the film coated. We don't have a 40 milligrams, but between 40 and 50, it's so close. So also in extenuating circumstances where we've got a patient who needs to go onto dolutegravir because they're a third-line patient, and then we would use the 50 milligram tablets in that situation. But the big problem is, these children who use under 10 kilos start on half a tablet, and then they get to 10. Now you need to give them 32 milligrams, and we're stuck. So, but doesn't mean we don't try. We try, and when we get to 10 kilos, then we have to make a plan. Okay, what about raltegravir? So raltegravir, we try and avoid where possible because of cross-resistance to dolutegravir and the fact that it's BD dosing. There are granules for suspension on section 21, the chewable tablets, and there's film-coated tablets. They're also not bioequivalent, so the doses are different between the chewable and the film-coated. But we try and avoid it because you get cross-resistance to dolutegravir, and we don't really want that to happen. Traverine, there's 25 and 100 milligram tablets. They are dispersible as well. We use it from 2 years and 10 kilos. Adult dose is 200 BD, so it's going to be 4 tablets a day, 2 tablets BD. I have seen overseas experts giving it once a day, so you can do it in that situation. But we generally don't use much anymore because of the pill burden and the cross-resistance to the first-line regimens, and also the fact that the third-line regimen without it seems to be so robust as probably we'd only really reserve it for patients who've got sort of quite considerable Darunavir resistance. Next drug I want to talk about is TAF, tenofovir alafenamide. It's a prodrug of tenofovir, as is TDF, but it was originally said that it's got less effect on the kidneys and bones. I saw a meta-analysis recently which suggested that basically they're equivalent in terms of effect of kidneys and bones, except where the patient is on a booster. So if they're on ritonavir or cobicistat, then the TAF does seem to have less effect on the kidneys and bones. But otherwise, it doesn't seem that there's a major difference. But where it does help, especially in pediatrics, is it's a very small formulation. If it's used with a booster, it's 10 milligrams a day. If it's used without a booster, 25 milligrams a day. And the TAF fixed dose combinations are tiny tablets. The kids love them and can be given from 6 years and 25 kilos. Remember, TLD can be only given from, at the moment, 10 years and 35 kilos. So if you've got a patient who could benefit from TLD, they're on third line, but you could give them TLD, but they are over 6 years, over 25 kilos, you could definitely give them TAF. There are 3 formulations of TAF, I think, already registered with SAPRA. None is available in South Africa yet. We're hoping in the next month or 2 there will be. There is some worry about weight gain. It's not every patient that gets weight gain, and it's still not clear what's causing the weight gain. It seems like, similarly as with dolutegravir, it may be not the TAF that's causing the weight gain, but the absence of tenofovir. This patient were on TLD before, or TE before. The tenofovir was seemingly keeping down the weight. When you stop the tenofovir, it change to TAF, so then they gain weight. So it's still not clear, but definitely it's used liberally overseas, and especially in children. Right, what about our patients who are on third line and now need TB treatment? What do we do in that situation? Okay, because of the third line drugs, only the integrase inhibitors are compatible with rifampicin, obviously with dose adjustment. So the first thing, and I know it sounds silly, is make sure they actually need the TB treatment. Because in the old days, the patient's looking a little bit funny at you, we put them on TB treatment. But now it's got a major impact on their future. It could really wipe out their future regimens. We need to make sure they need TB treatment. Yes, there will be the odd case where, you just can't prove it, but you think they need it, fine. But really try and prove TB as far as possible. In adults, we're using rifabutin with the third line drugs. There are issues with rifabutin in terms of availability, in terms of dosing, both in adults and children. It's not quite sure exactly what the correct dosing is. And also means you can't use the fixed dose TB drugs. You could then got to split up the TB drugs in terms of availability is a problem, and in terms of pill burden is a problem as well. So there are issues with rifabutin. Other options would be to use a non-rifamycin containing regimen. Example, using levofloxacin or moxifloxacin, but then you need a longer course of treatment, like 9 months, or you could use an MDR TB regimen, but they're complex, lots of interactions and toxicities. And thanks to Professor Rabi for helping me with this slide. Okay, so there we have it. We've got our patients on third line. We started a few years ago, massive pill burdens. Okay, we're talking about in the old days, what was it? 9 to 12 tablets a day on third line. And yet, if you start a patient on third line today, we can get them down to, if they go into TLD, 1 tablet a day, 2 or 3 or 4 tablets a day. But we still got these patients on third line who are still on the very complex 9 to 12 tablets a day. Can we simplify their regimens? Because things have improved over time, but we like to put them on a regimen, and if they're suppressed, we don't change them because it's not broken. Why must we fix it? Yet, and this I see all the time with doctors, not broken. I get this. It's not broken. Why must you fix it? And yet I ask them, what phone are you using? Are you still using your Nokia that when you had to send an SMS, you had to write AAA, BB, CCC, and the only game you had on it was Snake? Are you still using that phone? No, we upgraded. We've got the fanciest phone, but our patients still have to go back in time and are still on lousy regimen. So you do want to look, you do want to simplify, improve it for them, even if they are suppressed, even more if they're suppressed, because then you can chop and change. So what you do is you take the regional mutation, put it back in the Stanford database. We discuss in our resistance workshop how to do this. Otherwise, we're happy to help you. And Stanford database will tell you if there is any derivative mutations or dolutegravir mutations. Will also tell you if the dolutegravir or derivative has to be double dosed or not. So poll number 4, which of these drugs has got a low genetic barrier to resistance? Is it going to be lamivudine? And it's multiple choice. lopinavir, ritonavir, dolutegravir, raltegravir, efavirenz, and that's about it. Okay. So we said the first thing while you're doing this, the first thing we said about simplifying is see if there are any derivative mutations, and if there are no derivative mutations, you can change them to a one-state derivative, 800, 100. Okay, instead of 600, 100 BD. Right. So the next thing we're looking at in terms of, and you'll see why I'm getting behind asking about genetic barriers. I think we can end it there. Very interesting.
Very.
And surprising.
Yeah.
Okay. All right, let's end this poll here before it gets worse.
Yes.
All right. Okay. So by implication, this talk is really for people, I think, who really are aware of third line issues and complicated. But I'm seeing that perhaps maybe we need to do a basic talk again on treatment failure and resistance. Okay. So genetic barrier, a low genetic barrier to resistance means that they develop resistance very quickly. Whereas a high genetic barrier means it takes a long time. All right. And lamivudine is correct. Raltegravir is correct. And efavirenz is correct. Let's see if dolutegravir is correct. Okay, I'm going to show you in the next slide. Clear up my screen. Okay, so this is a lovely table which shows you on the left the potency. That shows you the number of logs it will drop. So it will, ones that will drop the logs by 3 logs, that's a very potent drug. And the x-axis is the barrier to resistance, the number of mutations that need to develop high-level resistance. Okay, so let's take the ones that are low genetic barriers, the ones who need only one or so mutation to develop resistance. And you can see there's your 3TC, nevirapine is there, efavirenz is there, raltegravir is there as well. All right. Whereas your high barriers would be your dolutegravir, lopinavir, darunavir, maraviroc. It's not as potent, but it's got a high genetic barrier to resistance. Atazanavir seems to be just out of the high genetic barrier to resistance, but it's also well tolerated. So patients often do very well on that, even though it hasn't got as good a genetic barrier as lopinavir or darunavir. So those who answered that dolutegravir has got a low barrier to resistance, you can see it's got the exact opposite. Okay, it's got a very high barrier to resistance, but not as good as lopinavir and not as good as darunavir, ritonavir. And that's got implications because that's why we are seeing some resistance to dolutegravir. Okay. Good. So I hope that clarified that. Dolutegravir has got a high barrier to resistance. Okay. But raltegravir, which is its cousin, has got a low barrier to resistance. So if you've got a patient who is on raltegravir as part of the third line regimen, because that's what we gave in the old days, you want to get them off it because it can not only has got a low barrier, it becomes resistant very easily, but it causes cross resistance to dolutegravir. And we don't want to compromise these patients to cause resistance to dolutegravir. Right, so you want to get them off their raltegravir. So you want to have a look, can I simplify, get them off raltegravir? Also, raltegravir is twice daily, dolutegravir is once daily. Okay, so you want to get them off raltegravir. If they're suppressed, you can chop and change, take them off raltegravir, change to dolutegravir. If they are not suppressed, well then discuss with an expert. You may need a new resistance test to see if there's resistance to the INSTIs, or you might have to change the whole regimen. And remember, if there is INSTI resistance or they experienced with the INSTIs before, then you dose the dolutegravir at 50 milligrams twice a day. Someone once asked me, if they got dolutegravir resistance and they're on TB treatment, what do you dose them at? And so there is some data that you can dose them at 100 milligrams twice a day. But let's take the normal situation. They're not on TB treatment, you would dose them at 50 milligrams twice a day. Okay, so that's another way we can simplify. Firstly, to change darunavir to once daily if you can. Secondly, get them off the raltegravir and put them onto dolutegravir. Get them off the raltegravir and put them onto dolutegravir, but they must be suppressed. If they're not suppressed, discuss with an expert and see what you can do. Another way that we can simplify our third line regimens in terms of darunavir, we spoke about that can be changed to once daily. Darunavir, if there are no darunavir mutations. In pediatrics, discuss it with an expert in terms of dosing. Okay. Another way we can simplify is changing to TLD. Remember the algorithm says 2 NRTIs plus dolutegravir plus darunavir plus dolutegravir. But if they're on that whole regimen, see if you can maybe change it to TLD. See how much better was the AZT in terms of compared to the tenofovir, and you may in fact very well be able to rather reduce the pill burden by changing them to TLD rather than giving them AZT3TC dolutegravir plus darunavir. Okay. If they are virus suppressed on a third line ART, and you go back at the resistance testing and you can see they've got an active NRTI, you could change it to 2 NRTIs plus dolutegravir and leave the darunavir. In fact, if you can do TLD, well, it's a 1 tablet a day. It's a big win. Another way that you can simplify third line. Okay. Then there's one step further in terms of simplifying. And here we don't have much data. These are the patients who are virus suppressed. If they're virus suppressed, can you say, well, we couldn't use darunavir once daily in those days when they were unsuppressed, but now that they're suppressed, could we not maybe use them once daily? And once a month, I join a virtual clinic at Imperial College London, and they do this. Patients who've got low-level darunavir resistance and they're virus suppressed for more than 6 months, they will change them. There's not much data, but certainly the patient is complaining about twice daily. Discuss with an expert. There may be room in that situation to go to once daily, even though would you be starting with a regimen, you would not use it once daily. I have done this in some of my patients with very, very good results. That's numbers are small, so I can't. It's not a study. Okay. All right. Let's talk about dolutegravir resistance, because if you speak to some experts, dolutegravir is a beautiful drug with no resistance whatsoever. Okay. It is true that in a first-line patient on dolutegravir, very unusual to get resistance. Okay. But when you have things like drug interactions with rifampicin and the positive cations, then yes, you can get resistance. And especially remember the Nadia study, the Artists of Death study, which has showed fantastic results that patients are failing TEE can go into TLD with better results than AZT3T and dolutegravir, but they got resistance. Okay, 9 patients in Nadia had resistance, 6 with the AZT arm. Obviously, the AZT is not as good, but 3 with the tenofovir arm. So, as opposed to in the Nadia study, in the darunavir arm, there was 0 resistance. So dolutegravir is, and you remember that graph I showed you, dolutegravir is up there, but it's not quite as robust as darunavir. Okay, so you do get resistance to patients on dolutegravir, and we're going to see it. We are going to see it. There's no question. I recently came across a patient who had switched from TLD to a PI, and they were virally suppressed. That's according to the Clinician Society guidance. They were suppressed, so they could do that. And in less than 2 years, they had high-level dolutegravir resistance. Another one I came across, a patient who was on TEE and then switched to abacavir 3TC and dolutegravir. That we know is a bit dodgy, okay? From TEE to TLD is good from Nadia, but to go to abacavir, we're a bit worried. And in fact, they had intermediate resistance to dolutegravir 18 months later. But remember, we're using dolutegravir as first line, second line, third line. So we are going to see dolutegravir resistance, something we need to be watching for. I'm not saying don't use dolutegravir, but be very wary. And if you are going to do what I call a dodgy dolly, in going to dolutegravir under dodgy circumstances, then make sure that you've got something to fall back on, that they're suppressed on a PI. So if you go into dolutegravir and it doesn't work, at least you can go back onto your lopinavir, onto your PI. Okay. So that's talking about dolutegravir resistance. Watch this space. We're going to embrace this wholeheartedly. There's no question. Dolutegravir is going to be fantastic. We're going to have a wonderful ride, but then we're going to be very thankful that we've got the protease inhibitors to fall back on when dolutegravir stops working. Right, what about fourth line regimens? Now, I don't have any personal patients on fourth line. I try and avoid it if I can, but I have tried to help a couple of clinicians with their patients with fourth line. And it is very problematic at this point in time because we just don't have the drugs. Occasionally, we get patients who are CCR5 tropic, so we can use Maraviroc, but otherwise, you can't, as you know, generally most patients are CCR5 tropic in the beginning of infection. When they have extensive resistance, they usually have switched over to CXCR4, so Maraviroc will not work. So that becomes problematic. It's also very expensive. We need access to new ARVs, things like islatravir, lenacapavir, and fostemsavir. Islatravir, unfortunately, they discontinued all the trials because patients were dropping the CD4s. And I saw fantastic today, they've just announced that they're going to go back to the trials again with a reduced dose of islatravir. Lenacapavir is a capsid inhibitor. Also had problems. They were finding little bits of glass in the vials, but I think there was something to do with the vials that they were using, and hopefully that's been sorted out. And fostemsavir is also a GP120 blocker that also hopefully we'll be able to use. But we just don't have those drugs in South Africa at this point in time, and difficult to get access to them. So fourth line regimens are very difficult. There are some clinical trials, but more for adults. In fact, I just came across now a fostemsavir trial in pediatrics. So if you have these patients who are failing third line, reach out and we can see if we can get them onto a trial of some of these new drugs. But it's really generally not a good place to be needing a fourth line regimen. No, we've got three third line regimens. After that, we're not supposed to have a fourth line yet. And also, we just don't know how big the problem is, because the third line committee, no one says, that our patients are failing third line. They don't get feedback. And so it's very difficult to know how many of these patients are out there. It's very important, if you've got third line patients who are failing, get back to third line committee that they can help you, and also that we're aware of how big the problem is. But we don't have time for this case, unfortunately. It's a very interesting case. Okay, what about if your options are over and your patient you've got nothing left? What do you do? So in the old days, when we needed third line, one of the options was mega or giga heart, where there were 5 to 7 drug regimens. You just threw the book at them. There is some adult data on efficacy. Most patients just vomit them all up and they just don't work. But I had one patient, I haven't got time to show you, I've got the slides here, who's remained suppressed for something like 10 years until I got him onto a lovely 2-tablet-a-day third line regimen. So they do work, okay? And maybe, the old days they were superseded by the new, more potent third line drugs. But when we run out of options now of our third line drugs, maybe that's something that we can go back to. I'm not going to go through this case now because of time constraints. Okay, but he's been suppressed ever since, and I recently changed him from extensive resistance, needing third line back in 2008. I changed him now. He's been suppressed all these years, and age 19, I changed to TLD plus rilpivirine, lovely 2 tablets a day, and he's remained suppressed. Okay. Also, a situation which I've never had to deal with, but may come up. When you've run out of all the options, no more third line, no more fourth line, what do you do? So the one thing, we're talking about palliation here, is you don't want to stop all the ARVs, because wild type will come back and destroy this patient's what's left of the immunity. So you want to keep them on a tolerable regimen. Failing regimen is better than no regimen in this situation. Obviously, you're going to get more and more resistance, but if you're palliating the patient, no more new drugs after this, then we would rather keep them on a simplified, tolerable regimen, including 3TC, including tenofovir as well, things which weaken the virus, and just to palliate the patient. But as hopefully we won't have those situations, but just to bear in mind that that is a possibility. Right. So to summarize the way forward, peds, third lines regimens remain difficult, still big pull burdens. Adults are getting better. Dolutegravir peds formulations will make a big difference. The field is changing all the time. Review your patients frequently, even and especially if they're virus suppressed. If they're not virus suppressed, you need to deal with them, of course. But even if they're suppressed, review them, because you may be able to simplify. More and more we're simplifying to dolutegravir plus 2 NRTIs, but watch out for dolutegravir resistance. Please give feedback to the third line committee. We desperately need to know how we're doing, and can we improve matters? And as I say, even just to review your patients with the committee, just review. So my patient's been on third line since 2015. Can we improve matters? And we do that quite happily. The only way we learn what's working, what isn't, is we get feedback from you. And even if they're doing well, we would like to know about it. You know, saying who doesn't want to know that they're doing well? Okay, and we welcome discussion. Remember that they're your patients primarily, but we very much have a vested interest in them, and we would like to continue working with you in helping to manage those patients. Just to acknowledge 3 people who helped me with putting this talk together, and I think that's enough. If you like to contact us, you're welcome to on the helpline, the 082-352-6642. Can't always help you. That's the nature of the beast, but usually we do know who can, and we'll be able to steer you in the right direction. But you're welcome to call us. We do try and help people while you're busy with the patient, to be able to help you. You don't have to wait for an expert to phone you back. All right, I think I can stop my slides there. Stop sharing.
Thank you very much, Dr. Leon. That was quite empowering. And colleagues, I've just shared on the chat. If you found this topic to be way above your head, it's okay. There's 2 programs you can do: a basic HIV management course if you are a doctor or a clinician, and you can do NIMART if you are a nurse. Start there, then do the advanced HIV management course, then do the resistance course, then come and do the extensive. But Dr. Leon, as always, a very good teacher. He took a very complex issue and sort of summarized it. Dr. Leon, as you go through the chat, one question from me: the 7-week-old child with extensive resistance, is there a potential for these mutations to disappear at some point, or the child will have this mutations for life?
That's a good question. So we think that at this point in time, patients who do have resistance, it remains with them for life. And often with transmitted resistance, it's virtually as if that is that patient's wild type. And I've seen these where those mutations persist for years and years and years and years, because that's what they were born with. They don't always disappear. But we know that once there's resistance is there, that resistance is there for life. With the single dose nevirapine, it was very different, because there was 1 dose nevirapine, and a lot of those mutations did disappear by 18 months. But that's the exception. Once these patients have got transmitted resistance, or they've got their own resistance that's developed because of non-adherence, that resistance tends to be lifelong.
All right, maybe let me make a last follow-up, then we go through the chat. So with regards to then the treatment of this child, I mean, how was the child? I mean, the child is too young. 7 weeks is more than 1 month, but
Yes.
half the drugs you're talking about might not be
right. Don't ask. The child is alive and well and fully suppressed, but don't ask what we did.
What you did. All right.
Okay.
So let's refer. If you find such a child, it's important to discuss with a specialist. I think that is.
I gave very bad advice, which just happened to keep the child alive, but it wasn't good advice. I'm not proud of what I suggested. We put the child onto a holding regimen until it got old enough to be able to go onto third-line drugs. We got special permission to give third-line drugs at a year of age, which nobody would dream of using darunavir at a year of age, but we did, and the patient suppressed beautifully. But it was very challenging. It was a long time ago. We didn't have options, and so I'm not proud of it, but the child is alive and well today.
Superb. And maybe talking about holding regimens, there was a comment, but I don't see it anymore. Someone was talking about 3TC monotherapy on the Q&A, but I think
they gave it. At 6:31. So the patient was refusing Kaletra, refused the pellets. Okay, can't swallow tablets. Okay, what do we do? CD4 is 21, so they put them on 3 monotherapy, which is acceptable in the situation. It's just going to buy you a bit of time for the child to get older, to teach him to swallow the lopinavir pellets, lopinavir tablets. We're seeing this with the lopinavir solution. We are seeing patients not tolerating it, and the pellets are not much better. I'm sorry to hear. There is the 4-in-1, which is going to be available in the next month or 2, and that will also be an option if it would be available. You could use could try that as well. They've managed to mask that lopinavir pretty well. So that's something else that you could try. But I think in the meantime, the 3TC monotherapy is a temporary measure, no problem, as long as the CD4 count is remaining stable. But it's not a long-term solution.
So coming to resistance and long-term, or I mean, slow progressors.
Yeah, I don't actually understand the question. That's why you left it, eh?
Yeah, not sure whether slow progressors would survive better, irrespective of whether there's resistance.
I haven't seen anything on it, so I'm sorry, I don't have that answer. But the Secha will answer it for you in the chat.
No, I don't know.
Okay. Then there are a lot of actual people asking about patients. An adult female patient changed to a backup of 3TC and dolutegravir. She doesn't know why. I suspect it was due to acute kidney injury. Yeah, that could be. Okay, it depends what they were on before. If the patient was naive and was on TLD or even TEE, but they were suppressed, then it is something that you could do. You could use a backup of 3TC and dolutegravir. The 3TC dose you would need to adjust depending on the EGFR. These days, we're only adjusting it when the EGFR goes below 30. So you could keep them on the combination of a backup of 3TC, 600, 300 plus dolutegravir is just 2 tablets a day. That you certainly could do. I can't think of any other reason in adults. It might. The other possibility is that she's a young adult who was a teenager on the back and put on a backup of 3TC efavirenz before, and then transitioned to backup of 3TC dolutegravir when dolutegravir became available, because the backup of 3TC is the adolescent regimen. So that could be the other possibility. Okay. Correct approach to a patient on double dose dolutegravir for carbamazepine who can't use any anti-epileptic, only have access to rifampicin based. I don't understand this. So I think what you're saying, but maybe you can just type on the chat. You're saying a patient who has to have carbamazepine. So there you would use, we don't like to say double dose, but it's given twice daily. It's not double dose. Double dose would be 100 milligrams once a day. So it's twice daily dolutegravir for carbamazepine. Yes, that's acceptable. And I think now they're saying they've got rifampicin, they need TB treatment with rifampicin. So that's a situation where I think you could go 100 milligrams twice a day, as you would in a patient who has got dolutegravir resistance and needs twice daily dolutegravir, and then is going to need TB treatment as well. I'm not 100% certain. I think we would need to just check up on that, but it could be a possibility. Okay. We've discussed that one. Raltegravir came before dolutegravir. It was the only integrated inhibitor we had in those days, and it served its purpose. It was very good. And it's just, new drugs arrive on the market. And so I don't think there is a major place for it. Some countries in Africa do use raltegravir in neonates. We don't, because we worry about causing resistance to dolutegravir. So generally they would say, and I think at this point in time, if you really had to put a patient onto an integrated inhibitor, a young child, and they're too small for dolutegravir, then you'd have to use raltegravir at this point in time.
Leon, with regards to third line and fourth line sort of regimens, are we heading towards? Do you think it's possible to have a standard third line, looking at the current changes happening first line?
So it's a good question. Yeah, I think so. Look, a lot of countries in Africa do that. They'll say like do TLD plus darunavir, then they're dosing it twice daily. It becomes a twice daily regimen. So I think you could do, but I think there is room for simplifying, for changing to a once daily regimen if you can do once daily darunavir. But yeah, if you don't have resistance testing, or there's resistance, but you don't have the expertise to sort of use the algorithm, you just want to just give it standard. Yes, I think that would work. It would work. But you're also seeing patients who don't have any PR resistance put on a third line regimen, and they don't need it. They just need adherence. You know what I'm saying? So that's the downside of doing that. Okay. Yeah. Psychiatrists switch back to efavirenz from dolutegravir. Efavirenz got a much better brain penetration despite the low genetic barrier towards resistance. That's I'd have to check on that. because as far as I know, dolutegravir does have some brain penetration. If they are susceptible to efavirenz, you could switch them back to efavirenz. But if they're resistant to efavirenz, there's no point you could do that. So in a naive patient, that there may be some value to that. I can't comment. There is a graph to have a look, and I'll have to go back and look at that. The last time I looked at the graph, dolutegravir wasn't on the graph, so that's why I can't tell you what the brain penetration is. But I have looked at it, I think, and it certainly does. There is some brain penetration, but I'd have to go back and compare. And I'm not certain that that is always a good thing to do, especially if the patient has failed an efavirenz regimen before, as a lot of them have.
So Leon, with regards to your recommendations around simplification of third-line regimens,
yes,
the simplification part, do we need to consult the third-line committee, or it can be done at the front line? How does that work? Yeah.
So I think it's always a courtesy to always consult with the third line committee. Even if you're going to put the patient, even if you've got a patient, for example, where you're pretty certain they need third line, they've got PR resistance, but you're pretty certain that TLD will be fine. Okay, or you've asked an expert, I would still, as a courtesy, just let the third line committee know, this is what we've got. We've put them onto TLD. Are you happy with that? And same thing here is, can I simplify this patient? They are fully suppressed. There's no reason why you can't. If they're fully suppressed, you can simplify, change the reltegravir to dolutegravir. But as a courtesy, I would just drop them an email to say, I have done this. Are you just to let you know that I've done this. You don't even say, is it okay? Because we know it's okay. If they're not suppressed, then you do need to consult with them.
There's an interesting comment on the chat. It says, why 3TC is used in second line, even when it has a low barrier to resistance.
Oh.
Actually, want to say you need to come back.
I hit that slide, Leseko. Let me put it back. Yeah. I hit the slide to save time. I said, after it's too long, I'm gonna let me hide that slide. Oh dear. Yeah. Let me put it back for you. Shame. I'm sorry about that. You see, it was never hard slides.
Yeah.
Let me find that slide again.
Problem. Hey,
yeah, you caught me out. Okay, I don't know what's happening. Why?
Be a member and make me happy, because I'm pushing Dr. Leon to reply to your question.
Oh,
hey.
Why can't I find this? Let me go back. It's fun. Okay, there we go.
Yeah.
All right. So I apologize for hiding the slide. Let me put the slide back for you for your benefit.
Yeah.
Okay, Leseko, you saw it, hey? You saw it on the. Okay.
Yeah, so I'm seeing it, but I also think you need to come back, you know. I mean, sometimes the people who miss earlier sessions, we think we are moving with the same people, only to find
but they're not. Okay, yeah. Right. So why do we keep reusing 3TC? Why is 3TC in first line, second line, and third line? Okay. So let me take you back to a study which was done by Joe Aaron in 1995, a long time ago, where he gave patients 3TC monotherapy. Remember, we never do monotherapy, but there's a new drug. They didn't know what it was all about. He gave them 3TC monotherapy. And you can see on the y-axis is the viral load. You can see that when you gave 3TC, you had a fantastic drop in the viral load, a 1 log drop in the viral load. But then after 2 to 4 weeks, the viral load starts going back up again. So what does that mean? Remember, viral load equals viral replication. So the virus stopped replicating, and now it's replicating again. It's multiplying again. Why? Because you need one mutation for high level resistance, the M184V. So that's what's happened. The viral load is going back up because the virus is now multiplying because it's resistant. But if you look at the viral load, it doesn't go back to baseline. It's always about a half a log below what it was. Okay, so the virus has got this resistant mutation, okay, weakens the virus, so it replicates less rapidly, and the viral in fact drops a half a log. Now, 1 log drop for an NRTI is great, but a half a log drop is still acceptable. And that's why, because we don't have so many NRTIs available, you can reuse it, because in first line, it's great, it's a 1 log drop. In second line, which is a great NRTI, in second line, it's an acceptable NRTI with a half a log drop. In addition, the mutation 1N4V will partially reverse resistance to tenofovir, D4T, and AZT, and that's why another reason why we use it from that point of view. So it's because we don't have so many NRTIs and it still has some utility, and that's why we're using it. And that's also why, for example, we think that in Nadia with dolutegravir and tenofovir, which does the same thing, that you still have very good results because both the tenofovir and the 3TC are dropping the viral load somewhat as well. So I hope that answered your question.
Thanks, Leon.
Okay.
But you still need to come back so that we
With pleasure,
keep
with pleasure.
dealing with the basics.
Yeah.
Yes.
And yeah, we need to do a resistance test, a resistance workshop as well with you guys as well. Okay.
Yeah.
Sarah from Swaziland wants to know, would love to change patient TLD if possible. How can we show an active NRTI in these patients? Yeah. Most genotypes will only give us information on the NRTI the clients failed, but this is often in second line. So that's a very good question. So the Western Cape started this practice, and I don't know if it works or not, but this is what they do. They say, and I haven't seen the studies, and I think the National Committee is also going to do the same thing. They say that that in studies where there is no circulating tenofovir resistance, okay, TLD will always be active. So in other words, even if there's archived or hidden tenofovir resistance, if there's no circulating tenofovir resistance, TLD will always be active. And that's what they use. Obviously, you've got to do a resistance test to see that there's no circulating resistance. And then they would put them on TLD. And we think the reason why that works is because, yes, there is archive resistance, but in the circulating virus, there's no resistance. Because dolutegravir is so rapid, drops the viral load within a month. By the time the virus wakes up and says, oh, there's tenofovir here, I must send out the resistance strains, they're already suppressed. Okay, so we think that's how it works. So you could use that in that situation. If it's a 0 score for tenofovir done on your patient now, even though may have archived resistance, you can in that situation. Whether it works or not, I don't know personally, but I say I'm basing it on what the experts in the Western Cape are telling me, and that's what people are doing. Okay. Can you switch a patient from T with a viral load of 1000 TLD? Yes, you can. Okay, so there's the Nadia study, which we discussed last time, saying that you definitely can, and it's better. The viral suppression is better than AZT, 3TC, and dolutegravir, and that's going to be in the new guidelines. So can you do it? Yes. Are you allowed to do it in the National Department of Health? You'd need to speak to your provincial powers that be. Some are allowing it, some are not allowing it. But in all situations, if you've discussed with an expert, and you can cover yourself, so discussed with Dr. Lesejo, right in the file, then you would be acceptable. But if you're a nurse, I wouldn't do it on your own bat. Okay. If you're a doctor, you could take it on your own cognizance. But if you're a nurse, phone on the helplines or speak to Dr. Lesejo, and if he says, yes, you can, you can. But the results are really good, and it's better than the AZT 3TC. In addition, it's 1 tablet a day. It's much better tolerated. So yes, you could certainly do that. Okay. In case of dolutegravir resistance, would darunavir have to be specialist initiated? So yeah, so certainly with dolutegravir resistance, it would need to be discussed with the third-line committee. I think more just so that we're aware of those cases. But they wouldn't have to go on to darunavir, right? If it's a first-line dolutegravir failure, they've never been on darunavir before, never been on a PI before, you could put them on lopinavir, you could put them on atazanavir, or you could put them onto darunavir once daily. Okay, as a second-line drug, you wouldn't need the third-line twice daily dosing of the darunavir. So in the adult guidelines, it seems that if they've been on the first-line dolutegravir for 2 years, 3 high viral loads in that time, you could switch them to at the moment, the guidelines are saying lopinavir, and you don't need to have a specialist doing that. But in pediatrics, where we're doing resistance testing on those patients and you're picking up dolutegravir resistance, you would then need to discuss that with the third line committee. Okay.
As you take a deep breath, I have an interesting question for you. There is a pipeline of long-acting ART injectables, etc. Do you foresee an impact on third line and fourth line regimens in terms of simplification or even
Brilliant question.
That's a better third line. Yeah.
Brilliant question. Okay. So where was that? What time was that?
Oh, it's me.
Oh, it's you. Okay. All right. Okay. So the present okay, so the present injectables that we're going to have coming up soon, okay, is cabotegravir, rilpivirine. Cabotegravir is like dolutegravir, rilpivirine is like the NRTIs. So the problem with that is that if they've been on a first-line regimen and failed efavirenz, then most likely they won't be able to use the rilpivirine. And if they fail dolutegravir resistance, they won't be using cabotegravir. So strictly speaking, that injectable that we have now is a first-line regimen. Okay, they're suppressed on first line, yes, they could do that. Okay, if they're totally naive, yes, they could do that. So the concept is fantastic, but in terms of, and that's why the problem is how are you going to find out the patient is non-adherent? Well, they failed first line, okay, now they go into the injectable, sorry, you can't. Okay, but there are other drugs that they are looking at that are long-acting, which can be used, and I mentioned some of those now, you know, lenacapavir and islatravir, you know, can all be used. They are looking at longer acting formulations of those, but the cabotegravir and rilpivirine, unfortunately, is not going to be for this class of patient, you know, or that they might need other stuff with it. So you can have your cabotegravir injection, assuming that there's no INSTI resistance, can have a cabotegravir injection, but they'll still have to take the other ARVs every day. So yeah, that's really the problem there. Okay. Right. Are there any patient studies looking at trials of the issue of abacavir and dolutegravir with those who failed first-line TE? Not yet, but we do need it, because certainly in pediatrics, we don't know that you can use abacavir as a second-line drug with dolutegravir. We suspect you can't, okay? And I showed the one case that I saw where they had dolutegravir resistance, but I don't know that any trials are being looked at. But it is something we want to. Is NIH looking to apply NADIA study results? Definitely, that's going to be in our new guidelines. So don't worry, just watch the space. It's going to be there. Ask Lesejo, he's on the guideline committee. Okay. How would you manage the pre-third line? Very good question. What do we do if the patient, especially now? Say again?
I thought you must somehow clarify what is pre-third line as well.
I know what it is. It's a patient who needs third line, I think, okay. Who needs third line, okay. Oh no, maybe it's not.
Because I'm thinking of the TB concept, you know, there was pre-XDR concept, if you have at least one mutation, and so I'm not sure which one this one is.
No, so maybe I'm misinterpreting it. So maybe they could just tell us what it means. Okay. All right.
All right. Chibuaya, please comment further on pre-third line, maybe in the chat, so that we can try and understand it better. Because in the HIV world, it's not the TB world. So I just want
Yeah. So Nicoline's question is saying, because you know, in terms of abacavir instead of TLD, yeah, for sure in renal disease, but I mean pediatrics is probably a much bigger market as well. So we need to know from their point of view as well. But at this point in time, I would not use abacavir in that situation. You could use AZT, but the problem is with renal disease that they're often anemic and you can't use AZT. But yeah, I would be very wary about applying NADIA to abacavir.
Cool. Okay, colleagues, 5 more minutes and we start to call it a quit, Dr. Talia. All right, we can go through a few more. Okay. Good question. The patient with on-rail tegra failed and you can't do a genotyping test. Can you just double dose the dolutegravir? Sadly, I saw one patient where they did that and that patient ended up with resistance to everything. High level resistance to dolutegravir. You need to know what's going on. It's not good enough just to double and carry on. Okay, unfortunately it doesn't work. And that patient unfortunately passed away. She was one of the 4th line patients that I was consulting on. Okay. 4-in-1 being available in the next month. Will it be available? It will be available in both, but next month will be in the private sector. Government sector will only be in the new guidelines, we're hoping, which will be out in the next couple of months. Prior exposure to a PR-based second line, change to TLD while on drug-resistant TB treatment at the time was suppressed. 1 year later, viral load is unsuppressed. After Hitchcock, still unsuppressed. Okay, so this is sure. Was on a PR regimen, and we do. I need more information here. You know, I think maybe
just
Asanda
drop me an email.
Poswa, if you are here, do raise your hand, and then I will give
Or
you.
with 5 minutes left, maybe send an email.
Okay,
To
okay.
the others. Okay.
Sure.
Okay. The reference for stopping tenofovir EGFR less than 30, just Google it, you'll find the reference there. It was a real world study where they said, yes, the levels of 3TC are higher in renal failure, but 3TC is such a safe drug. Let's have a look at it. And they found no problems whatsoever. If you Google it, if you still can't find after Googling it, then get back to me. I Googled it, that's how I found it. Okay. Are you changing all patients on AZT, 3TC, dolutegravir to second line to TLD suppressed because of Nadia? We're not yet because our guidelines haven't changed, but if you're from out the country, you could certainly do that if they're suppressed.
I think we have answered the key ones, Dr. Leon.
Is there a chance of reverting back to tenofovir-based FTC once the AKI is resolved? So there, I'm not an adult physician, the second will maybe help us, but my understanding is depending on what the cause is. If the cause is tenofovir, then you certainly cannot do that. But if there's another known cause, dehydration or whatever it is, then once they're stable, you certainly could try them back on tenofovir. You agree, Lucifer?
I fully agree. The cause, treat the cause. And actually, if there was a secondary cause, then there's no reason why TDF cannot be used because.
Right. But if it's caused by tenofovir, then you don't want to do that.
Yep.
Okay. Oh, this one's moving. Interaction of dolutegravir and some anti-epileptic drugs. Okay, so this is a very interesting one. So we know carbamazepine, initially they said, you know, if you're in a pinch, give dolutegravir 50 milligrams twice a day. And yet if you go onto the Liverpool app, it says give dolutegravir twice a day. And same thing is, if I'm not mistaken, I'm pretty certain I checked Phenobarb the other day and they said the same thing. So check on the Liverpool app. Okay, it may be that things are changing, but I don't want to tell you now until I'm 100% certain. But I seem to remember seeing that on the app. Okay, but you should all be using the Liverpool app. Get on your phone and you just put in just search for Liverpool drug interactions, HIV drug interactions, or Liverpool eye chart. It's a fantastic tool, and put it in there and you'll be able to see exactly what you can do. Okay, so pre-third line is what I thought. Person who needs third line, but they haven't got it yet. So if you've got the third line drugs and you're pretty certain you know what they need and your pharmacist doesn't mind you using them, you could do that. If it's an urgent situation, low CD4, let the third line committee know, let me know, and we'll speed it up so it can be put through. But if you've got the third line drugs and you're pretty certain you know what they need, or you discuss with an expert who tells you, you certainly can do it in that situation. And while you're waiting, especially the CD4 count is low, if it's going to be a long period of time, you don't want to keep them in the same failing regime because you're going to get more and more resistance, and then what you saw in the resistance test may not apply. But I think if you've discussed with somebody and you've got a pretty good idea of that's what they need, you could, and you've got the drugs. Not all the facilities are able to use third line drugs for other patients. You're not supposed to, but some do have extras. I think, I don't want to say officially you're allowed to do that, but if your facility doesn't have a problem with you doing that, there wouldn't be an issue with doing that. Officially, the stance may be very different. So I don't want to give you an official stance on that. Okay.
All right, Dr. Leon.
Are we just going to stop there?
Yes, I think we should pause there. And just to.
Wait, I just want to quickly answer.
One more you want to go through? All right.
Yeah. Okay. If a resistance test says the PIs are all susceptible, it only means one thing: they're not taking their treatment. Okay, we discussed it on our resistance workshop. We'll do it again. Join our resistance workshops or join the SECHOs. It says susceptible to all the PIs, that patient is non-adherent. That's all it tells you. Okay. No point in doing another resistance test because they're not taking the treatment. What you do is tell them to take the treatment properly for 1 month and then do the test. Okay, then you've got a better idea. If you say, are you taking your treatment? They all say yes. Okay, so, and you're not going to catch them in a lie. You won't say, look, I need to do this test. You have to be adherent. Are you really taking a treatment? They're not going to say, no, you know what, doctor, I was lying to you. Okay. So what you do is you say, I want to do a 7,000 Rand test in a month's time, but it's only accurate if you take every dose for that month. Just do me a favor, just for 1 month, take your treatment and then do the test. Okay. And then you've got a better chance of showing the results. But all that tells you they're not adherent. Sorry, I had to answer that one. Okay. Lesejo, I'm happy to end it there.
Thank you, Leo. There's one question for me. Can you repeat what you said about dodgy dolly?
Dodgy dollies. If you're going to do a dodgy dolly, make sure you've got a backup with a PI that still works.